Good afternoon, everyone, and you are welcome to QPS TalkTime. You can follow us on social media, and we'd be grateful for any activity that we can generate today just using Twitter or X at QPS TalkTime. You can watch back the previous QPS TalkTimes on the YouTube channel at National QPS. We've just recently, I think, put up some of the last episodes that we did. So if you want to catch up on any of those, and even over the last few years, they're all available there. And you'll also find us on LinkedIn. So encourage you to get involved on the social media end of things today as well. Just some NQPS resources that we flag up each time we come on, and the prospectus there is a list of all of the educational programs that are available, some of them online, some of them in person, for 2024. We'd encourage people to check that out and find things that might be of interest or of use to you. The Q community, we certainly encourage people to join the Q community and then be active within it. This is a community of healthcare improvement and safety interested professionals across the UK and Ireland, and lots of Q events, and we're going to ask for your help in the Q exchange at the end of the session today. Walk and Talk Improvement podcast is there, so please check that out. We have some new episodes that have just gone up recently on that. So I'd certainly encourage people to check that out. And then finally, we really are looking for people's help. We're working on a national quality and safety competency navigator at the moment. And we've put a lot of work into this with our colleagues in UCD over the last year. And we're at the point now where we'd like to test it. So the QR code there will take you to sign up to become a tester. And that might be something you're keen to do at your site, because these things all work very well in the classroom, but when we take them out into the real world, we need to see how they're going to work there. So we would really, really value your help in that, and we'd encourage people from all backgrounds, please, to help us with that. So today's session is about just culture, and this is something I think that the importance of has really emerged in the last few years from many safety critical industries, and so we're going to hear about what just culture is, and that's an important thing because it is a complex idea, and we're going to talk about what it is and the factors that influence it. Get an update on the Patient Safety Act, and I think in particular, you know, the bits of Patient Safety Act that will be important in influencing just culture within Irish healthcare. Gain some insights into the resources that can guide staff to promote a just culture, and learn about using just culture during a crisis. And to help us with that, I'm joined by two speakers who are very passionate about just culture. So I think you'll see that come through. I think passionate because they believe it's right, but also passionate because they believe it can really help us. So I want to welcome Lorraine Schwanberg, who is Assistant National Director for Incident Management with NQPS, and Professor Noirin Russell, who is a Consultant Obstetrician Gynecologist at CUMH in Cork, and is the Clinical Director for the Irish Cervical Screening Programme. So you're both very welcome, and thank you. This is an important topic. I'm going to hand over to Lorraine first, who is going to use some slides to really set the scene a little, tell us what just culture is and what the HSE is doing about it. So good afternoon.
Thank you, John. Thanks for inviting us to speak on this important topic. As you mentioned, it's an area I'm certainly very passionate about. One of two areas in terms of when an incident happens, how we support staff, how we treat them just and fairly, and equally how we respond to patients, service users and their families. So I'm going to give you a quick overview in terms of what just culture is, just for anybody to whom it might be new. So I suppose while we're gathering, and the chat is very active, maybe just for colleagues who are joining and participants who are joining the webinar, just to maybe reflect in terms of what does just actually mean to you? What does that mean if somebody is going to treat you just and fair? So generally, I suppose with us in incident management, we talk about fairness, responding to the staff appropriately. So to your initial question, John, I would say just culture is absolutely critical for safety, for patients, and for the well-being of our staff. It is an important component of our safety culture within the HSE and just generally across the healthcare system. So we know a safety culture is a culture of safety where there's an atmosphere of mutual trust in which all staff members can talk freely about safety problems and how to solve them without fear of reprisal. So it's that important element of creating psychological safety for persons to speak up, even members of the public, and responding to those concerns. So this is really just demonstrating where just culture has come from. So some of you will be aware of the kind of the past dialogue was being very much around a blame culture. So there's always been a perception that incident management might be related around blame and establishing who did what with regards to an incident. And we know that that is extremely negative, corrosive, and does not show an appreciation of the kind of wider system setting that persons work in and the different contributing factors as to why an incident might happen. A no blame culture, then, on the other hand, almost takes a leap in the completely opposite direction. And that didn't sit quite right either, because persons do have a level of accountability, professionalism, and in particular, it does not accept any persons who may act deliberately to harm patients, or where there's a complete disregard around safety in that. So we need to find a balance in terms of making sure that staff don't experience a culture where there's blame, or that that we don't hold people to account where there was quite significant harm due to deliberate acts. Very, very rare, those instances. So just culture is really born out of that understanding. It is one of the principles of our incident management framework in the HSE for a number of years now. In the IMF, it is described that very clearly it does not lay blame with an individual practitioner, so they should not be held accountable for system failings over which they have no control. And we all recognise the challenges that colleagues are working in. It does not absolve staff of the need to behave responsibly with and with professionalism, so we all have that responsibility. And it doesn't tolerate conscious disregard of clear risks. So we know in systems and processes that people might take shortcuts for whatever reasons, and those processes might be very unworkable, very difficult, but where there is maybe an attitude to disregard any kind of safety measures, you do want to establish that and understand that better. Importantly, staff feel psychologically safe both to report incidents and to ask for help when faced with an issue beyond their competence. Okay. So here are a couple of quotes, a little bit wordy. I know you'll probably get a copy of these slides so you can take them with you, but I suppose just to hone in on the first one. Trust is a key element of reporting culture, and this in turn requires the existence of a just culture. So as staff need to trust us, senior managers, in terms of how we're going to respond, that we're going to respond without blame, and that we're going to take a measured approach and look at the wider system for learning with regards to that. Okay. Here, just a little image to demonstrate some of the system challenges and how easy it can be to make for an incident occur. It won't surprise you that a lot of the learning in terms of a just culture has really stemmed from the aviation industry, which always seemed to be at the forefront with kind of learning and developments around safety science. But just culture was really born within the aviation circles, and to the extent that just culture is specifically written into regulation, and it's referenced within European aviation safety standards as a key requirement. In the context of in medical incidents, just culture deviates from strictly non-punitive safety culture, and it certainly takes a systems approach to incidents, and it benefits. The key benefit is really that that will lead to increased reporting, very open culture, and it encourages that open dialogue with patients and those impacted by incidents, where our staff can actually undertake that role without any concerns about repercussions. So this is just to demonstrate, I suppose it's a very simple diagram, kind of taking that system lens when there are incidents. We know that incidents happen. They happen for a number of different reasons. We look at a range of different contributory factors and have various tools that we outline to explore those issues. So often incidents will be the product of a system design. So there might be some challenges around processes, procedures, there might be some gaps in training or access to training, and it might be related to the environment that we're working in. So these there generally is a chain of events, and what we should do is understand how these contributed to the incidents, support the staff, and try and learn from those incidents. Where there is an incident and it is recognised that there might have been some decision making around actions to be taken, and there was a risk in certain procedures and that, we need to again understand that. We need to remove incentives for at-risk behaviours. So why are people maybe taking shortcuts? Is it just unworkable? Has this actually led to better outcomes in different scenarios? It's really understanding that piece, creating incentives for healthy behaviours, and increasing situational awareness. So really focusing in on the human factors piece. And that would possibly require some coaching and support for staff. So the area that Just Culture really wants to hone in on, which as I mentioned is extremely rare, is where there is a conscious disregard of unjustifiable risk. And of course, those that would require to be investigated further and followed up with the staff as well. And for the purpose and benefit of patient safety, that would need to be addressed quite promptly as well. So one of the tools that we've developed in the HSE is really to support managers and staff in terms of kind of, I suppose, exploring those potential encounters or issues that might arise where staff are involved. We have developed a Just Culture guide that kind of leads staff, managers through an algorithm to explore whether there were any kind of system factors that influence decision making, or whether there were some individual factors that where the staff member may need support. And that isn't to say disciplinary action. They might just need support or additional training and that. And certainly that's a key component that we need to, I suppose, sign up to as an organization, make sure that they do get that support. So the Just Culture Guide is available on our website. It's endorsed in the Incident Management Framework. And I think we'll be sharing some links as well so that you can access those documents as well. Okay. So as I mentioned, it's almost like an algorithm. It just supports managers in considering maybe some other elements that might have influenced decision making or certain actions taken by individuals, and it explores a number of different scenarios. So the key one, as I mentioned, that we absolutely need to address to maintain safety is where there's any evidence of deliberate harm being done to anybody. And that's almost at the forefront. Then it explores whether there's any health issues that the staff member maybe needs support with that might have influenced their actions. And then it looks at foresight and substitution. Foresight is consideration where the deliberate intent to harm and health tests have been discounted. This analysis establishes whether protocols, policies, and procedures have been followed, and actually were they workable, and any other mitigations around that. And then substitutions, how would somebody else might have responded with that guidance? What's the culture generally? How do other have similar incidents occurred, and so forth. So. And then there's actually another step which considers any other further mitigations, and it gives you some advice as to how to manage or support that staff member in those different scenarios. The next slide, you'll see a visual as to how that looks, what that tool looks like, and that document has some guidance attached to it. You won't be able to read the detail now on this slide, but sharing the links to that as well. So while we, I suppose, within the HSE very much support a just culture, it isn't easy. I think Noirin will speak to that as well. Certainly, we know culture is always a challenging space, and not to requote what's been said many times, culture eats strategy for breakfast, but culture is obviously is the way we do things, and we really want to, I suppose, with this webinar, drive that forward, inspire you, give that understanding around why just culture is important. The staff need to feel empowered to report and speak about incidents and near misses. And it's not just around incident management now, obviously with my role, I'll often take an incident management lens to it, but how do we look at different patient outcomes? Do we have systems to explore those better? Do we have good reporting mechanisms around that? And then understanding the system's approach to incident reviews, and particularly the language that we use when we do incident reviews. Do we get all the staff involved to provide their feedback, and are they able to, I suppose, share their experiences quite openly? We know that a key challenge around Just Culture can be some of the external influences, not least maybe the media putting quite a significant lens on certain scenarios, and that can be quite challenging. Accountability gets referenced quite a lot in terms of Just Culture, and really, I suppose it's our role to explain what accountability means when it comes to incident management. So it's important that we have systems in place that recognize, allow staff to report, where we can get to the bottom of what happened so that we can identify the learning. Those staff are supported, that we're completely open and transparent with patients and their families, that communication is strong and robust, that they're regularly updated, and that is maintained so that we don't lose trust. And that's where, for me, accountability comes into the fore and is important for the organization. It's not about blaming individuals. And then key alongside the Just Culture piece is that we do support staff, because as I mentioned, even the open disclosure piece, when you look at the Patient Safety Act and our policy in that, it is always the lead clinician who has those open disclosure conversations. So how do we support them, that they're confident and able to do those, but even the staff involved in incident, how do we support them after that? Again, topic that's close to my heart, and they do all intertwine and go hand in hand together. So these are the well-recognized stages for staff of being involved in an incident. Nobody wants to be involved in an incident, not the patient, service users certainly, and that's not why they're receiving healthcare, but staff equally do not want to be involved in incident, and these are recognized stages as to, I suppose, learning that you were involved in an incident and how that impacts you as a person, and the actual kind of almost the different stages of being quite shocked, chaos as described, intrusive reflections, and being haunted by the incident, and then actually just the general perception around the incident, and really that ongoing journey where they do require support throughout that piece. And I think at this point I do need to reference the Assist Me model, which the Open Disclosure team have developed, which is a really important and helpful tool for managers to use to support their staff. So in practice, what does it mean to actually foster a just culture? So staff support is really key. Treating staff just and fair if there is an incident, having these support mechanisms in place, debriefing, doing after action reviews with them, using the Assist Me model. Incident review processes need to be fair. We need to have clear terms of reference. We need to follow fair procedures. They need to have an opportunity to comment on any of our review findings. It's really important that we are mindful of our language around that when we do write reports, and that the focus is on the system learning. And for me, I think a really key in the just culture feeds into the restorative culture piece, how we actually respond and work with patients and service users when the incidents happen, making sure that they do get an open and transparent account as to what happened. And we are doing quite a bit of research in this at the moment, just to understand where we're at in the HSE, and to take further learning from that. And yeah, I might hand back over to John at this point.
Thanks, Lorraine. That's a great overview of Just Culture, and I think we will get the chance to chat a little bit later after hearing Noirin, and we can maybe explore some of those things. And I'm kind of keen to hear a bit more about research and things like that as well. So I'm gonna hand over, just in the interest of time now, to Professor Noirin Russell. Noirin, it's a pleasure to welcome you, and just to hear your perspectives on Just Culture, your experience of it, and some of the things that you feel we can do to support it, in particular in the times of crisis. So, Noirin.
So thanks, Lorraine, for I think a wonderful description of the culture that we would really like to have in the HSE. We'll all acknowledge that this isn't easy. If this was easy, we'd have a just culture. We wouldn't be sitting here having a webinar. And what I want to do in this talk is I want to tell you a story about humans. We are humans who receive healthcare. We're humans who provide healthcare. And I think at the center of all of our responses to unexpected adverse events is that human piece. And I want to, I suppose, share some reflections that I have. I've had the opportunity of working as clinical director for Cervical Check, and I've had the opportunity of looking back and reflecting on the Cervical Check crisis, which I think there are some really important learnings from this time. And I would like, I suppose, just to tell the story, and I'm really happy to take questions, but I'm really conscious, and I will be very careful, that this is not a story about blame, because I think that would be so easy for me to come in and say, oh, you should have done X and you should have done Y. But these are observations that I think we could do better in times of crisis. It's hard, but I think there was some learning from the Cervical Check crisis. So audit is very common in healthcare. We're all very familiar with it. We look back to improve. The first thing we do is we define a standard. We don't expect to find 100% adherence to the standard, but there's evidence that if we look back, we will improve. In 2018, there was a high-profile court case reported in the media about abnormalities found on a cytology slide review during interval cancer audit, and about non-disclosure of interval cancer audit results. And I suppose my first reflection is, whenever there is an incident, it is really important for everybody, for the whole population, and for the people affected, that we quickly determine, that the system determines, does an action need to be taken to stop more patients coming to harm? What are the facts of the incident and what are the implications? Is this a patient safety incident or a known potential outcome or complication? And crucially, it's important that we keep the person or people at the centre of the incident informed of what is happening. This means that patients must have access to senior HSE staff, both clinical and non-clinical, and that will require a mix of expertise in a very highly emotionally charged situation to make sure that high quality information is available. I don't think there's anything in this that people would disagree with, but I'm going to take you through a timeline and how quickly things can go awry. So on the 19th of April, we first heard that there was a litigation case about, and it was in a newspaper. 25th of April, there was a report about a settlement. 2 days later, the Minister for Health declared no confidence in Cervical Check programme management, and the following day, the clinical lead of the programme stood down. This is how quickly things can go in a direction that really we might not feel is the most just. So in the early days of the Cervical Check crisis, I think it's fair to say the failure to explain the limitations of screening had happened before the crisis, and that was across medics, patients, the public, the system. So this came as a huge shock. But in the early days, there was a lack of clear explanation for stakeholders that the cancer diagnosis was never withheld from women. The results of audit had no impact on treatment or prognosis. What the role of audit in screening and in cancers was, and that finding abnormalities on review does not mean they should have been seen during screening. And I think the absence of a coordinated communication from senior medics and HSE management was compounded because the lead clinician was not involved in the crisis management. She had stepped down. The frontline staff were not linked to the senior HSE management. And importantly, affected patients were not linked with the staff with the expertise to answer their questions. All of this led to missed opportunities in early communication, and that led to the perception that finding abnormalities in review was proof of a poor quality programme. It's not a surprise for any of us that crisis communication needs a multidisciplinary tailored approach. And again, the communication to the public needs to focus on reassurance. People need to know, am I at risk? Are other people at risk? Are there immediate patient safety concerns? And will all necessary steps be taken to ensure no further patients come to harm? In doing that, it's important to explain clearly who's not at risk and offer a helpline for people who have queries about whether they are at risk, because it can be uncertainty. This guide that on the right-hand side is a guide that we worked collaboratively with IARC from the WHO about communicating in a crisis. And one of the advices is that information should be consistent, clear, timely, and based on credible evidence. We agree on that. It's important to identify an appropriate lead spokesperson, and it's important that that spokesperson is getting information from across the system and across all different specialties. So both clinical, managerial, communication, to be that lead to explain what's happening and give regular updates. Is that what happened? I'm afraid not. So the ongoing communication needs, as I said, would be in a crisis. You'd identify your clinical leads and you'd link them to the communication experts, identify key messages, how best do we communicate them, have a multi-stakeholder internal HSE group, which has clinicians, managers, really get a clear internal understanding of what's going on, and then create a guide, frequency asked questions by the internal experts, including the frontline staff, to ensure that you could make a very clear external communication and keep frontline staff in the loop in an ongoing way during the crisis. During the cervical check crisis, colposcopy clinics became a call centre. Everyone that had ever attended the hospital was transferred. This is a quote, from a colposcopy staff member. Everyone that had ever attended the hospital was transferred to us, and the solicitor started ringing. I never switched off. It was the last thing I thought of before going to bed and the first thing I thought of when I woke up. Now, here today, we would never think about putting a call centre into a busy clinic that was expected to keep on running their normal service and take all of the calls. But this is the sort of thing that can happen in a crisis unless we think about it in advance and unless we learn from what we did in other crises. My third reflection is that open disclosure needs careful planning, and rushing into open disclosure can cause harm to patients, to staff, and to the wider population. And unfortunately, at the time of the cervical check crisis, there was an incredible sense of urgency because the disclosure of the audit results, it wasn't quite well understood that didn't impact on the patient care that they needed immediately. And there was headlines like this one, 48 hours to inform women. And I think we need to reflect on that, and we need to learn from what that felt like for patients, because they've told us really clearly what that was like. So patients, we NSS, National Screening Service, co-designed a process of a consultation with patients in the 221 plus advocacy group. This was done by an independent group, Quality Matters, and this was really important consultation to us because we recognised that the patients were the experts in what this felt like, and we needed to know what this disclosure process felt like. So I suppose it goes without saying that it is really important that the system is open, transparent, that we discuss any incidents in an open and transparent way. But what happened in 2018 was we rushed things. And for the patients, this is what they described. The overall process was confusing, unclear, disorganized, random, dishonest, traumatizing, stomach punching, shocking, insensitive, and it felt like that people were prioritizing orders and law over human needs and well-being. The communication that they received was lacking, unclear, incoherent, clinical and difficult to understand, and the emotional impact that had on them was it caused painful suffering, anxiety, anger, frustration, and it left people with a sense of loneliness, isolation, feeling abandoned, let down, and frightened. So we've got to have a balance. Of course, we need to share information. We need to be open and transparent when something has happened, but we need to plan and we need to train people, and we need to make sure that we keep the patient and their needs, that we care for our staff so they can care for patients. These are quotes from the patient report. This patient report is online, it's available, and it's a really important read. I have learned so much from my experience of talking with patients affected by this crisis. One patient said, "This shouldn't have been dropped on me without warning or even knowledge that an audit takes place when there's a cancer diagnosis. My personal circumstances led to an extreme psychological reaction. I didn't want this aspect to be overlooked in the inquiry." Another patient said, "The consultant and nurse met me in the rooms and briefly explained audit and that results of one of my smears had been revised. I was not given any advice or comfort from the consultant. I left the hospital in shock by myself, knowing that my cancer could have been prevented. I've never felt so alone." I think we can do better than this. And that's exactly what this slide is about. So again, patients in the 221 plus advocacy group were so committed in this process, and they wanted to give us, the system, advice about what to do better for future people who would find themselves in the same position. but they gave us such rich advice about how to care for patients who get a cancer diagnosis after screening, how to discuss audit, and how to discuss the results. I'm not going to go into this because I'm in the interest of time, but it's really important we listen to patients who've been through an open disclosure process. But what I'm also going to share with you is some information from a project we're working on about the healthcare perspective of audit result disclosure. And what our colposcopists said about this time is that we were so removed from the truth of the narrative that even our colleagues didn't really get it. There couldn't be all that stuff in the media if there was nothing dodgy going on within colposcopy. From one moment to the next, they saw us as the perpetrators. We went from being the ones that tried to cure them to the ones that had caused the cancer. Some patients believed we'd thrown their smear tests in the bin. We had to contact all of our patients. We were given no directions. It was hard because no one explained why it was happening and why it was instigated, and we did not have the language to do it, and we were not prepared for it at all. So we talk a lot about training staff and making sure people have the resources to do open or to run or to provide open disclosure meetings. But in a crisis, it's even more critical that that training is available. How did staff describe 2018? They said that there wasn't sufficient planning going into the meetings. There wasn't enough consideration about the impact on patients. They didn't have enough time and support to prepare, and they didn't feel confident about participating in the meetings. And very importantly, they knew the meetings hadn't gone well. They felt that they hadn't provided the type of care that they wanted to for their patients. And that impact on them, 88% agreed the crisis affected them negatively on a personal level. 80% found it difficult to separate work life from personal life. And 60% experienced negative physical effects, headaches, low energy, insomnia. We, the system, have got to care for our staff so they can care for patients. Harm in healthcare is common. I've read a lot about it as I was preparing for this webinar. The lowest figure for harm in healthcare that I found was 10% of patients attending hospital are harmed. Some of the estimates are far, far higher. So complex, providing healthcare, it's complex. There are multiple ways that people can come to harm. And in the aftermath of death or disability or through the processes that follow, we can actually compound that harm unless we get this right. This is a beautiful paper that I highly recommend. I can pop it in the resources. It's about using restorative inquiry frameworks and restorative approach to heal and learn from adverse events. I think it's really excellent, and I commend it. And that brings me to the Patient Safety Act. There's been a lot of discussion about this act. This is the nature of any act. The language is very, very legal. It is a legal document. It is really important that we, the system, the HSE, the leaders, management, open disclosure, QPS, that we make sure that in following any act and any legislation, that we keep humans and humanity at the center of all of our processes. And that's my plea to everyone involved. We need to be really, really careful about our patients and our patient care and make sure that we don't. I see a lot of notice about timelines and rushing things. I hope in this presentation I've outlined my concerns about why rushing can be really, really serious and can lead to trauma. So in summary, there's an immediate, in the context of a crisis, I know I've talked about a kind of a general national crisis, but I think these are reflections that are adequate and appropriate for a smaller level, for an individual incident in a hospital setting. The first aid is first. Determine if there are other patients at risk. Do it as quickly as possible. Communicate who is and who is not at risk and take steps to remove any immediate risk. And keep your index patient involved in the communication about what you're doing. Then plan your communication at the time of crisis with everybody's expertise. You need to get your internal comms right because you need everybody in the system to understand exactly what's going on. And then then that will help guide your external comms. And it's really important that the lead spokesperson is supported to communicate. And what I've learned as a clinician is that not just being a clinician and having the expertise, that's not enough. That doesn't make you automatically a good communicator. You need to understand, you need to have your communications experts, you need to work with your communications experts to understand what is the message, how do I best explain this science, this complex medical stuff, how do I put it clearly enough that people can hear and can understand what I'm saying? Because sometimes as clinicians, we don't have that system understanding of what people hear when we speak. Open disclosure finally needs careful planning. It's important that all stakeholders are involved in planning patient meetings. It's important there's clear links between the management, frontline staff, and I suppose this is something I learned as an obstetrician very early on. We have one chance to get this right. This is something we say a lot in perinatal bereavement. And we need to, in an open disclosure meeting, there is one chance to get it right. We have got to make sure that staff are trained so that they provide the best type of open disclosure so that our patients get the best care. That's what all of us want. And it's important to acknowledge that rushing into open disclosure without the full facts can lead to harm for patients and for staff. I'll leave you with the quote about just culture. We all want this, but it's hard. And I'm really looking forward to the panel discussion. Thank you.
Thanks, Noirin, and thank you for sharing those thoughts and insights, I think, into your experience at Just Culture. And I'd like to invite yourself and Lorraine back, maybe just for us to have a little discussion. And we might go to Anita in a moment just to see if we're getting some questions from our panel. But I might just start for both of you, you know, and like you said, Noirin, this is something that's desirable, but it's hard. And I think it's probably one of those things that never becomes easy. I think it's probably something you have to continuously work at because it brings you into places that you're vulnerable and exposes everybody's vulnerability, I think. But, you know, listening to you both, I was thinking of, you know, and I was categorizing them as 3 H's, you know, the honesty that's needed, you know, to develop a just culture, the humility that's needed, and the humanity that's needed. I think there are 3 important values. And I just wondered, are there other important values, Lorraine and Noirin, that we need to be bringing up and talking about that really help this to happen? Because we know that culture isn't something we can just open a box and sprinkle it around the place. You know, it emerges from people, I think, having clear values and demonstrating them through their actions. Noirin, maybe to you first, kind of just, you know, are there any other values there that you think are helpful in your work?
I think the 3 H's that you mentioned, John, are nail it very, very well. But I think as a general principle, it's knowing and acknowledging that any of us could end up in a crisis. By virtue of working in healthcare, any of us could be in a crisis tomorrow. That's the nature of healthcare. And I think that vulnerability about when something goes wrong as healthcare professionals, we immediately feel shame because we don't want anything to go wrong. We want to live and work in this perfect world where we have perfect outcomes and everything is, we're perfect, the outcomes are perfect, the patient's experience perfect outcomes all of the time. So that's our ideal. And that perfectionism standard is not achievable. We all know that, but we just like to fool ourselves. So I think the first part of a just culture and that development, because we're here today to talk about development, is acknowledging that any service could find themselves in the middle of an incident. Any person can find themselves in the middle of an incident. And when that happens, you need support.
Yeah.
That's it. That's you're not going to be able to go it alone. You are at your most vulnerable. You need all the supports. And of course, ideally, all of that supportive network relationship would be before there in advance of the crisis. That's the dream. And that's maybe what we're here to talk about.
Yeah. Yeah, and you're right. You know, the system has to look after all the people of healthcare. You know, it is important. Everybody has needs. Lorraine?
I suppose on the trend of talking about H, I think for me it's about being heard.
Okay.
So
Yeah.
I think staff need to feel that they are being heard when they are raising issues, when they are raising concerns. Not that we're just demanding answers when the incident has happened, but that we can demonstrate that we are responsive, and equally patients and service users want to be involved, want to be heard, want to have that ongoing communication. And certainly within my team and some research that we're doing around with Trinity around incident management and review processes, the lens is always around learning and recommendations. But for me, it's like a big component is about that relationship piece afterwards. that respect for one another, that we will tell you what will happen, that the staff can speak openly, and that restorative piece creeps in. Yes, people will be angry. That is a normal reaction, but try and help our staff manage those scenarios, and that's why we need to support them. So yeah, I think for me it's about being heard from lots of different angles and managing that relationship.
Yeah, thank you. And even as you said, the restorative, we had Joe Rafferty and Amanda Oates on the podcast here, or the webinar a year or so ago. And again, they're big advocates of restorative just culture, which is about healing, which is saying that there's another H for us, kind of, that's something that we should be trying to address all of the harms and put them right. And often justice in other senses just seeks to address the harm through retribution rather than trying to heal. So I think that's something we should be thinking about. I'm going to pass over to Juanita just to see, can we get some questions from our panel, from our audience for the panel. So Juanita.
Thanks very much, John. And really, really fascinating. I suppose when you look at some of this stuff, it is in the time of crisis that you see all the lessons and the things we should have done. And there's a question there, if you're starting out on this journey, where or how is the best place to start before the crisis? So if I was to say to you that thinking about all that you know at the moment about the learning, the research that's out there, the audits, all of that evidence at the moment, if I was a manager within the service and I'm looking to create an environment that when something does happen, it lends itself to a just culture going forward, what would those tips or suggestions be?
Will I start?
No pressure.
Go for it. I'll let you start this one, Lorraine.
Well, I mean, that's a challenge with culture, because culture is the way we do things around here. So it's about already nurturing that kind of setting that, maybe you have team meetings where you will talk about incidents, focus in on the learning pieces, so that incidents will sadly happen, but that is your staff know what the response will be. They know that adds values. Set expectations around some of our policies, about being open and transparent. And then when incidents do happen, that we do debriefing with staff, we support them, we use the Assist Me model as best as we can, that we plan for open disclosure. And I think the piece around open disclosure, I think in particular for Noirin's learning that she's shared with us, and certainly is informing our open disclosure policy about, that preparedness is really important. But even if you're in an acute setting, there is an incident, it's okay to say at the beginning, we don't know all the facts, but make sure that you give that apology and that is the normal way to do things. We have lots of training around incident management that incorporates just culture pieces. We have lots of resources on our website page. So already immerse yourself in that kind of, I suppose, inform yourself what it means to be just culture. Be mindful about language, I think in terms of when an incident happens, if a manager comes in and says, well, who did this? What happened here? That can be quite damaging, but actually just having those that just general approach to system learning, even if it's in a kind of a low level incident and things like that. Well, let's see how we could maybe address this going forward, or how can we improve on this scenario and things like that. Subtle things will make a big difference to your staff, I think.
Brilliant. Thanks, Lorraine, for that. Noreen, do you want to add anything?
Yeah, I suppose I really like the assist model. And I know that's something that that Lorraine's team have promoted. And I think that first piece, when you're in absolute crisis, when the incident has happened and you're just in shock, just acknowledging the first acknowledging that the human you are caring for, this is awful for you. You're in an awful situation. I think sometimes we're so terrified of what are the implications for acknowledging this is terrible, that we get paralyzed. I think that's such a critical thing to say. That bit is, and I'm really sorry that you find yourself in this position. Can you tell me your story? How did you get to here? Because sometimes there is something has happened and you're not even quite sure how you got there. And I think the parallel Assist Me model for staff is really, really critical. And I think it's all about, nobody ever, like, it'd be lovely if you could plan your incidents. It'd be great. So, next Thursday we'll have an incident, so we'll all be ready for that. And maybe having incident drills to say, well, if X happens, how do we react? Because we all know from our service what are the kind of things that happen. We look back on our incident forms, we can see what kind of things happen, and then plan how could we maybe deal with those better to make sure that we give better patient care. The patient's at the center of all of this. That's why we're all here. And it's just so hard to do this in crisis. It's so hard. But I think maybe if I could give that's, I've thought about kind of drills, like, incident drills. We do in my service, we do postpartum hemorrhage drills. We do what to do in an eclamptic seizure, but what to do when an incident happens drills, and how to lean into the rest of the system supports that are there, that it just doesn't feel like the frontline clinician on their own going, God, how am I going to do this? That knowing that there are supports there.
Yeah.
And I guess that paper, I really do recommend. I'm going to try to find it and put it into the chat. But this kind of, I suppose, restorative approach: who's hurt, what are their needs, who's responsible for meeting their needs, and what is what is their responsibility in doing that. Those sort of questions, the kind of the human piece can be addressed without knowing every single bit of the facts, because you don't have the luxury of knowing everything when you're in the middle of the incident. Sometimes things don't become clear till weeks down the road, but you have to get the human bit right. That's the urgent bit. The rest of it is less urgent.
Yeah, and there's always that piece, I think, in healthcare, like the vast majority of cases, staff are going back out to have another conversation with the patient or service user, and they don't have any context in terms of what's going on within the system, or they might have a lot of context and they're meeting people on the street or in the local village, and they're hearing things in different areas. And I think that one of the pieces that Bernadette Brooks had put in was the challenge in relation to emotions and how to combine the attention for emotions with focusing on the facts. And I think that's come up really strongly today, the necessity to look after the human side of things while also waiting until you have factual data to go, so that you can have an honest conversation, and being really comfortable to say, actually, we don't have all the information yet. We're going to investigate it thoroughly. And I think it comes back down to that psychological safety that you talked about, that we need a trust in the service, so that people are willing to wait for answers when we don't have them, but knowing that they're going to have somebody of integrity standing in front of them and willing to share what's going to come next, and to look for that information. I know that just Christine Fenton had mentioned around having patient partners involved in the process and potentially in the planning stage. I've seen that in the past in incidents where, it might have been a major incident and there might be a, communication with a broad range of people, and we've involved patient partners. Lorraine, just from your perspective, is there anything that you might like to add to that?
No, I mean, they've just been so powerful. We do a lot of work with Patients for Patient Safety Ireland there, and all our steering committees, they just add such richness. And Noreen, you gave a lot of examples there about how you've actually learned from the process, which is what we've been gifted with sometimes, to improve the process for everybody out there. But yeah, invaluable. Open disclosure, invite advocates to that process. Designated persons are absolutely key. They would be your liaison person for the patients, service users, and then within the hospital, the review team and that. So all these support roles are absolutely crucial and essential. Yeah.
Well, look, I'm going to pass back over to John. We've 2 minutes left. With a topic like this, I think you could sort of say we could continue to talk, and there's a really rich discussion, coming through within the thread. A lot of people with different experiences of it. But I hope that this has been somewhat helpful. So back over to yourself, John. Thank you, everyone.
John,
Thanks,
could I just mention
sure.
one little thing? I just touched on, we are doing some research with Trinity. Sam Cromie is leading out on it, and we're just trying to understand some of the pros and cons around our incident review methods, what works well, where it kind of nurtures psychological safety, how we get the learning out. But there are a couple of small pieces of research that we're doing in terms of how incidents have impacted on service users, patients, and also on staff and their well-being. So I think we're going to add the links to those surveys in the chat.
Yeah, they're coming up in the chat there now. So
you.
yeah, we'd encourage people to check into those. Thanks, Lorraine. That's great. And thank you, Noreen. Look, this has been a fascinating discussion. I did say to people you would bring your passion about this, and I think you certainly have. And I'd like to thank you for that. I think none of us, believe that we're there. We're not at the Just Culture destination yet, but there are elements of it. I think there are good conditions there, that we can build on. But we certainly want to go there, and it's not easy, but I think it's worth it. And again, just from the discussion, I think co-production of everything we do in quality improvement, but also in safety, is so critical. And I think, just culture is often framed as a reaction, when things go wrong. But I think it's also a way of building the energy for us to deliver safety, so that we can make our systems safer, and we learn much better, I think, from just culture. So thank you both for a wonderful discussion. I have no doubt we'll be coming back to this. I'm just going to close up now, kind of with just a few pointers. So that's us today, and then our next QPS Talk Time then is on the 25th of June, and so we have a bit of a break. But that is clinical audit, audit to action, and again, we'd encourage you to join us for that, and we will be sending out more details on that closer to the time. This is a special call out, please, to people who are Q members, and we would appeal across the world. Anybody who's a Q member across the islands of Ireland and Great Britain, please do vote for the project here, Patient Safety Learning, Reaching the Right People for Action. So you can check that out. The voting, I think, is open from tomorrow, I think, until the 12th of June. It is open to Q members, but we really want to get your vote behind this. So all the Irish Q members, but also we'd appeal to our friends and colleagues in Northern Ireland and in the rest of the UK. And I think that's it. I'd like to thank Juanita, who do all the work, and thanks to Lorraine and Noirin for a great talk time. And we'll see you in a few weeks' time.